So I want to take the opportunity here to unveil the idea of what I'm getting at in this book. And what I want to do is reveal this idea through 3 examples. I'm going to go through 3 experiments and then see what we can make of them. The first experiment takes place in an orthodontic clinic outside Kansas City a few years ago. They had this problem that a lot of orthodontic clinics have. They had a lot of teenagers who had braces, and they wouldn't brush their teeth. So they thought they would run an experiment. They took 20 of the kids, 20 of these incorrigible youngsters who just would not brush their teeth, and they gave them a special kind of toothpaste. It was plain label, but it said in big black letters, experimental. And they said that they wanted them to brush their teeth twice a day with this toothpaste. And they also gave them a kitchen timer. And they said, we wanted to do 2 minutes twice a day. So then they took another 20 kids who were clients of the orthodontic clinic, and they were going to make them the control group, but they didn't tell them they were going to be in the experiment. They had signed a generic consent form, and they were going to be part of this experiment, but wouldn't know it. So these kids with the experimental toothpaste went back, brushed their teeth, and after 6 months, came back, and they did an analysis of how their teeth, what the plaque surface was. And basically, at the beginning of the experiment, the 2 groups had the same baseline. They were about 70% coverage of plaque, so they had a lot of plaque on their teeth. After the 6 months, the control group, their plaque had actually gotten a little worse. Now they had up to 80% coverage of plaque on their teeth. And the kids with the experimental toothpaste had gotten actually much better. They had reduced the plaque coverage to about 50%. So there was, if you do the math, it's about a 40% difference from the 2 groups. So the question you all have is, what was this secret sauce? What was the toothpaste? What was this magic toothpaste that they gave these kids? Well, the answer is it was Crest. Crest with fluoride. It was the same toothpaste that the other kids were probably using. The difference was, the only difference was this kitchen timer. It wasn't the toothpaste at all. All the magic was in the kitchen timer. It was the fact that they had gotten the kids to care and pay attention and actually had kind of told them that they were going to be part of an experiment. So they were under observation, and that got them to change their behavior. Now, some of you may know this as the Hawthorne effect. This is a phenomenon that is well demonstrated and well documented, and it goes back to this factory in the 1920s. The Western Electric Company wanted to see if it could get its factory workers at the Hawthorne Works factory in Chicago, wanted to get them to make more relays, more electrical relays. So sometimes they would turn the lights up in the factory, and sometimes they would turn the lights down. Now what happened was, either time they would make it brighter or dimmer, the factory workers would increase production because they would see the lights would change, and they would realize, okay, the experiment is on, and they would make more relays. So that effect was called the Hawthorne effect. And it's basically a principle that when people are under observation, they tend to change their behavior. When you know you're being observed, you tend to act differently. And in medical science and in public health research, this is well known. It's a well-known confounder of experiments. It's related to the placebo effect, and it's something that they try to kind of compartmentalize and to get out of an experiment. But what they did in Kansas City, what they did at this dentist clinic, the orthodontic clinic, was they made it the whole point of the experiment. It was the whole premise of trying to engage this effect for the patient's benefits. Second story, we have to go to the bathroom. This is bathrooms, actually 5,000 bathrooms around the country. And in particular, we're looking at the bathroom scale. So this is some data that came out of a program called the National Weight Control Registry. It's run out of Brown University. And they have 5,000 people who have successfully lost weight. So these are 5,000 people who have lost more than 30 pounds and kept it off for at least a year. So if you want to know how to lose weight, these are the people you want to look at. These are the people who have successfully pulled it off. And you want to know, what are they doing? Well, so these people have broadly done some of the things that we would think about. They tend to have low-fat and low-calorie diets, and they also tend to eat breakfast every day. So we all kind of know those as general principles for weight loss. But the other thing they do, interestingly, is 50% of them step on a scale at least once a day. And 80% of them step on a scale at least once a week. This idea of self-monitoring and being observant of what their own behavior is incredibly important. In fact, it has a bigger correspondence with effective weight loss than diet or exercise. It's an incredibly powerful correspondent for successful behavior change. This is a woman on Flickr. She decided to put this to practice, and she took a picture of her weight every day. And she has this awesome pair of socks to meet every day. So it's the idea that you know, kind of one step further past what was going on in Kansas City. Not only does observation change our behavior, but tracking and monitoring ourselves can change our behavior successfully. So the third experiment that I want to talk about takes place here in London. Specifically, this is Whitehall Street. It's the epicenter of the British government. It's you know, the halls of Parliament at the end. Around the corner is 10 Downing Street, and Whitehall Street is lined with the Finance Ministry, the Department of Labor, all the kind of institutions of the British government. What Washington is to us, Whitehall Street is to Britain. So in 1967, there were a couple researchers at the London School of Hygiene that wanted to understand not just what causes heart disease, but who gets heart disease. And they thought Whitehall Street was the place to make that analysis. They selected 18,000 men from the bureaucracy of British government. They were between the ages of 40 and 64, the kind of the ages when people were most likely to get heart disease at the time. And they studied them according to their class. So at the time, the researchers called the British bureaucracy exquisitely stratified. It had this wonderful, for an experimental point of view, it was wonderfully structured by class. At the very top, there was an executive class. And then there was an administrative class, and executive class, professional class, administrative class, clerical class, and then at the bottom, the fifth class was an other. These were the janitors, the bookkeepers, the messengers. And so they now analyzed they ran these 18,000 men through the protocol of getting their weight and basic biometrics taken. And then they monitored them to see what would happen to them over time in terms of heart disease. Well, almost immediately, within a year, they had a very strong association between the rate of heart disease and class, the status of the people. They found that the people at the bottom in this other category were dying of heart disease at 4 times the rate of the people at the top. So the executive class was 1/4 as likely to die of heart disease as the people at the bottom. Well, of course, we know some of the reasons why this would be the case. So we know that diet and smoking, and there are certain variables, certain risk factors for heart disease. And so the researchers factored those out. They were able to adjust their numbers. But they still had an incredibly strong correspondence. People at the bottom, even accounting for everything we knew about heart disease, people at the bottom were dying of heart disease at twice the rate as the people at the top. And this they had no explanation for. They had no actual understanding of why this would be the case. They thought at one point it was genetics. They thought that the upper classes had certain inbreeding that gave them protective effect, but that turned out not to scale because there wasn't so much inbreeding down below. And what they realized, actually, was that status itself was probably the driver of this correspondence. That the people at the top, in the administrative and professional and even the clerical class, had a certain amount of control of their daily lives. The people at the very top were the decision makers. They were the leaders. When they wanted to make a decision, it stuck. And that authority, that command, went all the way through their lives into their own health. Now, the people at the bottom had very little control of their lives. They weren't making the decisions that kind of led them on their paths on a day-to-day existence. And the theory was that sense of control was an incredibly strong contributor to their health.